Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. Today, we're talking to Dr. Palak Trivedi about recurrence of PSC in patients who've received liver transplants. We'll also discuss colectomies and their role in preventing recurrence in certain cases. As well as that, we have some new research developments in NOR-ERSO. Now, since recording this, I have received my own liver transplant at St. Vincent's University Hospital in Dublin in Ireland. I feel great, by the way. I would love to tell you more about that, and we will do so at a later date in a special podcast. Hello and welcome to Living with PSC. Today we are talking to Dr. Palak Trivedi, who is Associate Professor and Honorary Consultant Hepatologist at Queen Elizabeth Hospital in Birmingham. Dr. Trivedi, would you like to tell us a little bit about your title there and what you do at the Primary Sclerosing Cholangitis Clinic at Queen Elizabeth Hospital?
Sure. So thank you very much for inviting me to talk today. So as my role is as a clinician, is to see people with primary sclerosing cholangitis, and we have a weekly clinic together with my colleague, Dr. James Ferguson, as well as people with other autoimmune or cholestatic diseases such as primary biliary cholangitis, autoimmune hepatitis, genetic disorders of cholestasis, and so on and so forth. And primary sclerosing cholangitis is the principal area of focus for my research activity. So I have a big interest in finding out why some people with PSC do very well and do not need to have things like a liver transplant and are relatively symptom-free, and why do other people with primary sclerosing cholangitis sort of do very badly. For example, develop progressive liver disease, in need of liver transplantation, develop recurrent episodes of infection, and so on and so forth. So try to find out why those differences occur. Is it something in the biology? Is it something to do with the age of an individual? Is it something to do with the sex of the individual, their inflammatory bowel disease activity, and trying to untangle why these things happen. And it's not just before transplant. We also have a large proportion of individuals in our practice who have had a liver transplant, and we are interested in studying why do some people, thankfully a small proportion, develop recurrence of their PSC, and how can we mitigate those particular risks from occurring.
Is there a relationship between PBC and PSC, and what's the difference between the diseases, if you like?
It's a very important question. So primary biliary cholangitis used to be called primary biliary cirrhosis, and that term has now been changed in 2015 to primary biliary cholangitis, because in that particular condition, most people, when they're diagnosed, are no longer diagnosed because they have cirrhosis, because they have end-stage liver disease. We now, in all realms of medicine, with advanced diagnostics, can identify people at a much earlier stage in liver disease severity. But that has caused some confusion, because primary biliary cholangitis and primary sclerosing cholangitis are very similar names. In very straightforward terms, primary sclerosing cholangitis more often than not occurs in people who have gut inflammation, inflammatory bowel disease. Now, that inflammation can occur before PSC, it can occur at the same time as PSC is identified, or it can occur many years later, and some people may have it diagnosed even after they have a liver transplant. With primary biliary cholangitis, that association is much, much less common. It may only be a few percentage people who have inflammatory bowel disease, whereas with PSC, about 70 to 80% of people will have inflammatory bowel disease. The second big distinction is which parts of the liver and which parts of the bile ducts are involved. In primary biliary cholangitis, it is only the small bile ducts within the liver that are affected, whereas in primary sclerosing cholangitis, whilst the small bile ducts are also affected, most individuals, about 80-85%, will also have involvement of the bile ducts that are outside the liver, the larger ones that you can see on a scan, whereas in PBC, you cannot see the disease on a scan. You cannot see the parts of the bile ducts that are affected. The other two or three big differences with primary biliary cholangitis, there is a very large body of evidence to show that treatment with a medicine called ursodeoxycholic acid saves lives, reduces the need for liver transplantation, whereas with primary sclerosing cholangitis, that evidence is much less convincing. Many people may take ursodeoxycholic acid and it will improve liver blood tests in some individuals, but the level of evidence that it actually helps improve things long-term, reduces need for transplantation, is not there, and certainly not there to any degree as it is with PBC. And when it comes to blood tests, they can look very similar. The liver blood tests can look exactly the same. But one of the antibodies that we see in people with primary biliary cholangitis is something called anti-mitochondrial antibody, AMA. And we do not see that in people with primary sclerosing cholangitis. So those are some of the differences between the two groups. The association with inflammatory bowel disease, fundamentally the part of the bile ducts that are involved are different. The response to treatment and some of the blood test antibodies that we find in PBC are not seen in PSC. So those are some of the overarching differences between the two conditions.
Now, of course, our topic this morning is recurrence in primary sclerosing cholangitis. In your experience, and by recurrence, I mean recurrence after liver transplant, I suppose, can you tell us a little bit about what the evidence is that the disease tends to recur in people post-transplant?
So because primary sclerosing cholangitis has certain features of it which tell us it's an immune-mediated, and in some people even say an autoimmune disease, we are not changing the immune system when we do a liver transplant. We're changing part of it because the liver's got lots of immune cells, but not the immune system in the whole body. And that's why we believe that people with autoimmune liver diseases, including PSC, develop recurrence. The evidence suggests that it's between 25 to 30% of people develop recurrence of PSC. Now, that's the time frame is very important to define here, and we'll say that that's about a 30% risk of recurrence at about 10 years after liver transplantation. How do we diagnose recurrence? It's very similar to our diagnostic tools prior to transplantation. It's with an MRI scan. We diagnose recurrence of PSC with an MRI. Some people also will end up having a liver biopsy, and the features are very similar to PSC in the native liver, the liver without transplantation. But after somebody has a liver transplant, there are many other problems or complications that can occur that look very similar. So our job is more difficult after transplantation in identifying whether this is recurrence of PSC or a complication affecting the bile ducts in a different way. For instance, if somebody has a liver transplant from a donor, and that particular donor had been starved of oxygen in the final moments before their sad demise, then that liver also would have been starved of oxygen for a significant amount of time. And that can induce some damage to the bile ducts that we cannot see with a naked eye, even before we implant the liver. And everything looks normal to start with, and it may look normal for some time. But as that time evolves and that liver becomes part of the recipient, we start to see some changes in the bile ducts as a result of that oxygen starvation or blood starvation that occurred at the time that donor was obtained. And those, what we call ischemic type bile duct changes, can look very similar to PSC. and they can occur with other in individuals who have liver transplants for other reasons. So trying to find out the differences between these two bile duct complications after transplant is very difficult. Some people say that recurrence of PSC should only be diagnosed after at least 3 months. Some may argue 6 months following liver transplantation, and ischemic type bile duct changes should only be diagnosed earlier than those time points. But there is a bit of an overlapping period, and there are times where we change our view, wherein we think recurrence of PSC is more likely or ischemia is more likely, depending on how that individual's condition behaves if and when they get recurrence.
So this is the liver from a cadaver, if you like, looks like PSC, but may not necessarily be PSC. Is that what's happening?
Yeah, so it doesn't look like it when we obtain the liver, but if somebody has passed away and they have been gracious enough to be an organ donor, then the mode that person may have died and the way that liver would have been, the time duration between obtaining that liver and implanting it, that may have resulted in some starvation of oxygen and blood to that individual's bile ducts after they've died. And there are very different types of donor that we obtain. We always like to get the best quality donor, and that is from somebody who has passed away from what we call a brainstem death. So the circulation is still going, but they've got no neurology to them to keep them alive, and so obtaining an organ that is from a what we call a heart beating donor is the gold standard. But sometimes, when in an era of organ shortage like we are in now, we obtain donor organs from people who have died following a cardiac arrest. And when that happens, everything looks okay with the liver and the bile ducts, but over the time, once it's been transplanted, it becomes apparent that those bile ducts are not okay. And that is not something that we can diagnose from the moment we obtain that liver. It's something that only comes to light after the transplant. And that is one type of liver injury or bile duct injury that looks very similar to recurrent PSC.
And would that mean that typically the PSC patients that receive those type of livers, that the liver will recover over a time, or will it always be hampered by the blockages?
It's a very good question. I have not seen it recover as such in people, but I've seen it plateau and in many individuals and not necessarily progress. There is no real way of knowing whether it's something is going to progress unless you follow people up over the course of time. There are certain factors that make it less likely or more likely to progress, or less likely and more likely to develop in the first place. But on an individual level, only time tells whether recurrence or this ischemic type biliary injury will progress or just stay the same and reach a plateau.
And these other factors would include things like the presence of ulcerative colitis or Crohn's disease.
Yes, indeed. So for recurrence of PSC, for example, our group and many others around the world have looked very hard at the risk factors that are associated with development of recurrence of PSC, and importantly, these are all what we call look-back exercises. These are retrospective studies where we look at everybody who's had a liver transplant over a certain time period, and we try to identify certain factors at the point they were transplanted or that have developed over the course of transplantation, and try to see what has been associated with the development of recurrent disease. And one of the strongest factors in that type of analysis has been the presence of inflammatory bowel disease, particularly colitis. What we've shown, and others have validated this observation, is that if people have had have got colitis and they've had their large bowel removed, then their risks of developing recurrence of PSC is much lower. And some may argue it's 50% lower. Our estimates are perhaps slightly lower. It's about 40% or 30% reduced if they have what we call a colectomy, a large bowel resection prior to the point that they have a liver transplant. Whereas those people who've got colitis and who keep their large bowel in at the point that they have a liver transplant, they do have that 30% risk of recurrent disease compared to individuals who've had a bowel surgery. In people who have bowel surgery after their liver transplant, they do not seem to have that protection. They have the same rates of recurrence as people who do not have a colectomy. So the first strong factor that we found was that colectomy prior to transplantation offers some degree of protection. It is not absolute. Sadly, there are very few absolutes in medicine, but certainly that is the biggest factor that reduces risk. And in particular, it's not any type of colectomy. It's people who have a colectomy and who keep their stoma, who keep their stoma bag, not individuals who have decided to have a join again, what we call a pouch procedure, wherein their stoma is closed and the remaining parts of bowel are joined up again. Those people do not appear to have that protective component to their colectomy operation. So having a colectomy, if you've got colitis, and keeping a stoma is one of the biggest protective factors that we found. That doesn't mean that we offer it to everybody, though. I mean, you have to have a reason for colectomy, and that is either going to be because there is precancerous or cancerous changes in your bowel, or there is ongoing active inflammation despite medicines that your doctors are giving you. So the way that we practice is that if people have ongoing activity of inflammation in their bowel, we have a much lower threshold at recommending bowel surgery than perhaps we do in people who've got colitis but no PSC. So if people have failed, and I use the word fail, meaning they have not had their colitis treated adequately with one, maybe two medicines, I would refer them to a surgeon for bowel surgery very early on, compared to what I would do in people who don't have liver disease. And that's because PSC will progress. We don't have a medicine to treat PSC. Colitis will continue to flare up. And if this person comes to a liver transplant, we know that having bowel surgery beforehand would have been beneficial.
And for people who don't have colitis when they go, I know there's about 80% of PSC patients that do, but for those that don't, is the procedure more successful?
It's a very good question. We have not done that evaluation because very few people who do not have colitis require bowel surgery. So there is no data, to my knowledge, showing that number one, that bowel surgery in that group offers the same protection. And number two, people who do not have colitis at the point that they undergo transplantation, they still do develop recurrence. Now, whether they've got inflammation elsewhere in the bowel that has not been looked for example, the small bowel, the stomach, for instance, if they've got inflammatory bowel disease in those areas, just as a sake of argument, we do not know how intervening with that helps. But what we do know is that even in people who do not have inflammatory bowel disease when they're transplanted, many of them do develop inflammatory bowel disease after transplantation, and intervening in those individuals early on, trying to get that colitis under control is very important, because that ongoing inflammation can protect the liver from damage, can protect the liver from developing blood clotting problems within it. And if, sadly, those individuals do get recurrence of disease, having that bowel surgery before they need another transplant will also offer some protection. So I can't say that it does offer a protection before transplant, because we haven't done those exercises in people without colitis, but it is an ongoing area of research.
And sorry, can you explain to me what a colectomy is exactly?
Sure. Yeah. So in people who have colitis, that means that you have inflammation in your colon, in your large bowel. Now, the gut is divided into various segments. When we swallow food, then it passes into our mouth and then into our esophagus and stomach. And then after your stomach churns whatever food and drink you have, and it passes it to the small bowel, that's where bile is released. Bile is released into the small bowel from your liver and bile ducts. And that bile is responsible for helping digest food, helping make the good things within food, and all the vitamins that you have in a more absorbable, digestible form. It helps breaks down fatty substances and so on and so forth. And when food is then passed through the small bowel, it passes into the large bowel, the colon, the part that we look at with a colonoscopy. That is the part of bowel that is affected when you have colitis. And a colectomy is an operation that involves removing either the entire large bowel or part of the large bowel. And so when somebody has that operation, it involves cutting out the start of the large bowel all the way up to the rectum, the very tail end, where a few centimeters are left. Now, people survive, very well without a large bowel, and there are lots of, and they live very normal lives, reportedly. And there are, but it's not something that everybody can tolerate or everybody wants to have. Nobody wants to have surgery. Nobody wants to have a stoma bag, but it is certainly something that is associated with beneficial outcomes in people with PSC.
And sorry, a stoma bag is the bag that is outside the body that collects waste. Yeah. It's a quite impactful,
Absolutely.
It would definitely change your life, put it that way.
Well, absolutely, and it should not be minimized. And if I ever have minimized it with any of my patients or anybody that I speak with, I apologize. But it is not a minimization or trivial procedure, which is why we don't offer it in everybody empirically. What we do is that in people who have ongoing colitis activity, or if they've got any precancerous changes, those individuals we know will come to need colectomy at some point, but we would rather do it early at a stage where the liver can cope up with such an operation, and certainly because a large number of individuals do end up needing a liver transplant with PSC, we would rather do it before than after if there is an indication. What is very difficult for us as doctors to treat and for patients to experience is if they've got ongoing active colitis that we have not managed to treat with medicine, and then their liver needs a transplant. The combination of both of those two things is very dangerous, which is why early on, when people's PSC at a very early stage, if colitis is not responding to one or two medicines, that is the stage where we say, actually, you'll be better off having an operation now rather than going through medicine after medicine after medicine.
Does the stage of the PSC affect the outcome of the liver transplant?
I see. So, we only do liver transplants in people who have a definitive indication. More often than not, that is because their liver has cirrhosis, and they may have developed one or more complications from cirrhosis, either persistent jaundice or ascites, hepatic encephalopathy, that confusional state, that happens because the liver is not filtering toxins, and those toxins go to the brain, or people who've had ongoing episodes of bleeding because of their liver disease, either vomiting blood or passing black tarry stools whenever they have a bowel motion. Some of those complications, so they have to have one of those indications. Less commonly, but certainly sort of not. It's not rare, but less commonly than that is if people have recurrent infections in their bile ducts, recurrent episodes of bile duct infections or recurrent acute cholangitis. That is a less common indication, but it is certainly something that we perform several times a year, transplants for that indication alone. We always offer antibiotics to people who suffer those complications, but if people are breaking through with increasing frequency or the antibiotics are not keeping things at bay, then that is another indication for transplant. Now, comparing those two broad indications as to who does better, who does worse, I don't believe there is any hard data, and certainly, we can look at that, but I don't. But so far, there isn't to say that one group of individuals do better than the other. What I do see, though, is that people who undergo liver transplantation, or listing for liver transplantation rather, in the absence of very high bilirubin values, in the absence of significant jaundice, in the absence of other organ dysfunction such as kidney complications, low salt levels in the blood, they tend to wait much longer on the transplant lists than individuals who have one of those other knock-on effects from their chronic liver disease. And because people with PSC are much younger, and this is a very UK thing, are much younger than individuals undergoing transplant assessment for other indications, they tend to wait much longer because our algorithms unfortunately disadvantage young people and they prioritize people of older age because they are more likely to succumb from their illness if you're older than individuals of young age. So I can't say that the indication for transplantation is a factor associated with worse or better outcomes, but certainly people with PSC tend to wait much longer when they're listed at the ages of 20, 30, 40, compared to people of other liver diseases who are listed at the ages of 50 and 60.
I see. Yeah, I mean, I think we don't really do partial liver transplants in Europe, but I did a podcast one time. I'm trying to remember which clinic I was talking to or which doctor I was talking to, but it seemed that the reason why people did better with partial liver transplants wasn't because of the procedure. The procedure was actually more complicated, but it was because the people going into the operations tended to be healthier than the people who were getting full liver transplants. This is in the United States.
So you mean that the type of liver transplant, you mean?
Well, so people with partial liver transplants were fitter, I suppose, or healthier.
Oh, I see what you mean.
Into the operation than people who were listed for a cadaver transplant, which ultimately they have to wait longer, and be sicker.
Yes. So mostly in the UK. In the UK, the vast majority of transplants are from cadaveric donors, people who have sadly passed away, and they have volunteered to donate their organs for the greater good. And we obtain whole liver organs for them. Sometimes we can split the organ in half because the liver can regenerate in part. And this is a common practice done for children because children can need smaller livers than adults do. So split livers are very commonly given to children, less commonly in adults. If you go to other parts of the world, such as Canada, another very developed nation, and they do as much or perhaps more liver transplant activity than we do, about a third of their liver transplants are actually split livers from people who are alive, what we call living donation. So either a family relative or a very altruistic benefactor has volunteered to give part of their liver to somebody who needs a liver transplant. And that is also done in the United States. And if you go to the part of the world where I'm originally from in India, almost all of their liver transplants are from living donors. And in fact, that's one of the reasons why we have such a significant organ shortage in the UK, is we do not have a widespread living donor program like some of the other Western countries do. I don't know whether that's a cultural thing or whether that's another reason why, but we certainly sort of would welcome that practice changing. But not everybody can be fit enough to accept half a liver, be that from somebody who's a living individual or that from a cadaveric donor. And that decision as to whether they can accept part of a liver is down to many things. And Niall, you alluded to patient fitness, but it's also down to the anatomy of an individual, whether the blood vessels, also the way that the blood vessels enter and leave certain parts of the body. And this is often this decision is often exclusively made by our surgical colleagues rather than physicians like myself. They would have looked at the scans, looked at the individual, and then made a decision as to whether somebody can have a split or liver graft and accept a liver graft from somebody who is living, rather than something that's a decision made by myself. But I encourage everybody and anybody who is undergoing a liver transplant assessment, if they do have a relative who is willing to donate part of their liver, to entertain that option. Nobody wants to put our loved ones at risk, but given the fact that people are waiting years for a liver transplant, if they're listed at a young age, and if you have somebody who can donate part of their liver, that liver in that individual will regenerate, and they will both the one that's donated as well as the remnant liver in the donor. So it is a very good viable option to discuss with your transplant assessing team.
It grows back incredibly quickly, actually, doesn't it? I mean, I think was it 3 weeks or something? It'll be 80% of the size.
Yeah, I mean, yes, it won't look exactly the same, but yes, it does regenerate pretty quickly, and within, I would probably say, a few months before the liver is sort of has regenerated to fuller capacity. But yes, it will still work, and within 3 weeks, the liver will be functional. Well, it is functional almost immediately afterwards, even afterwards. But yes, within sort of 3 weeks, people sort of are doing very well. Wounds would have healed. They'll be a little bit sore, as you would with any operation. But yes, we wouldn't notice anything physiologically different.
I suppose just moving on a little bit to treatment, are there, there seems to be an awful lot of research going on in the PSC area at the moment, but we still seem to be a little distant from being able to treat the disease. Would that be correct?
Yeah, I mean, it's what some people sadly call, the last remaining, black box of liver medicine. We have treatments for almost all other chronic liver diseases now, with the exception of PSC. And that's perhaps because PSC is one of the rarest liver conditions that exists, but it's not rare for anybody who suffers it, of course. And it's certainly not rare to me, where I see it day in, day out. But because it is rare, and because the progression of liver disease takes place over years and decades, not weeks and months, doing clinical trials takes a long time, even if we're not saying this particular medicine is going to stop a disease progressing and stop needing a transplant. Even if we want to have test a new treatment and say it's going to stop people getting cirrhosis, or it's going to stop people's bile ducts getting worse, that still takes years and years to test. And when you have a rare condition, then we need everybody to take part in those research activities who can take part in those research activities.
Is there anything that you have come across recently that you find particularly helpful?
So one of the big areas that we've been looking at is bile acid biology. And certainly when I started doing work in PSC more than 10, 15 years ago, there was no clinical trials of any value, in my opinion. But now we've got the first two big phase 3 trials, one of which is completed, one of which is completing, looking at altering how bile acid metabolism can lead to beneficial outcomes, not just in terms of liver blood tests, but slowing the rate at which liver scarring develops and progresses. So the fact that we've actually got to that stage is an exciting development in itself. And look, yes, if a trial is negative and we say it has made no difference to reducing the rate of scar tissue formation, reducing the rate of cirrhosis, everybody is going to be upset, including myself. But even with what we would classify as a negative study result, the wealth of data you get from that clinical trial, liver biopsies at the start, middle, and end, blood tests at several different time points, is so valuable that it makes designing future clinical trials so much quicker than anything that we've done before. So even though some trials may be negative, the fact that we've got this far with what we call a late phase 3 study with that body of data is incredibly exciting. Now, the NOR-URSO study, which is a modification of the ursodeoxycholic acid molecule, has got 20 plus years of data in animals showing that it actually cures and treats sclerosing cholangitis in those mice. Now, yes, it's mice, it's not humans, but the fact that they get a similar condition, disease type that we can reverse or at least treat and stop progressing is what led to it entering clinical trials in man. And we've now finished recruiting last year to those very big phase 3 programs, and those results will emerge next year. And I'm very excited about that. The other thing to say is that colitis in PSC is not the same as colitis without PSC. And up till recently, we've had no real studies dedicated looking at how we can treat colitis in people with PSC. Some people may be aware of an agent called vancomycin, which is an antibiotic used to treat infectious diarrhea. And there is lots of anecdotes and reports from various centres around the world showing that if you give vancomycin to people with PSC and colitis, the colitis gets better, and in some people, the liver bloods might also get better. In my opinion, there is no robust data showing that it will slow down what's going on with the liver yet. That doesn't mean that will never emerge. It just means that there is no convincing data yet. But certainly the data from our trial and other studies, some of which we're going to be presenting next week at our International Liver Meeting, shows that it helps improve colitis activity. We do need bigger and better trials, larger numbers, to prove that early observation. We are also doing trials of trying to change the gut microbiota by transplanting microbiota into the bowel from somebody who does not have PSC. And that strategy has shown to be beneficial in some animal studies. So we are now trying it in humans, and we will be recruiting people with PSC to take part in that trial later on this year. So those are some of the 2 or 3 elements which have excited me in the PSC drug development or therapy development space.
I think there's the Mayo Clinic is also doing a very large study with vancomycin.
Indeed they are, yes, absolutely. I believe that them and the Italian groups are doing studies in vancomycin, particularly looking at liver blood tests and liver-related endpoints. Ours are slightly different because we know how colitis activity behaves, and we can measure benefit versus risk in a much shorter time frame. And if we are able to get vancomycin or any other medication through the door quicker with good high-quality evidence, be that on colitis related to PSC first, then so be it. And so we are all trying vancomycin, fecal transplants, and other strategies, but in a slightly different way.
It brings me to this sort of microbiota question, which there's a huge amount of influence that it seems to have on diseases like PSC, but it's very, very difficult to study, and we're not quite sure if the links are causal or effective or...
So you're absolutely right. I mean, we are getting there. There's some very exciting data from the Far East. It's animal model data looking at particular cocktails of bacteria that appear to be causal, i.e., if you isolate them and you transplant those harmful bacteria to animals who do not have PSC, they get liver injury and bile duct injury that resembles a human condition.
We're talking about Klebsiella pneumonia, is it?
That plus certain types of what we call enterococci. Those ones appear to be candidates at least, and we need to prove that in other studies and other units. The reverse, though, in terms of trying to identify the beneficial cocktail, that is the next step that we are trying, and other groups are also trying. And hopefully, with the fecal microbiota transplant trials, we can refine what is going to be the helpful group of individuals, the helpful range of bugs.
Yeah, the other thing is that I did an interview with the National Institute of Health, the NIH in the US, and they had a very interesting study. What I believe was, they were keeping it open, but what I believe was looking for a viral link.
Yeah, I haven't come across viral causes for PSC. Certainly people have proposed that viruses may be the cause of primary biliary cholangitis, PBC, but I haven't come across that strong an argument for PSC. But there have been some approaches using what we call bacteriophages, which are viruses that inhibit particular functions of causal bacteria. And there are some data showing that might be beneficial in treating PSC.
There's some Israeli companies trialing bacteriophagia treatments for various diseases, and PSC was on their list, but they hadn't got there yet, I think.
Yeah, no, certainly there is. I mean, I know that the group in Yale are doing a study on bacteriophages in PSC. There was a very nice paper. I slightly disagree with the conclusions, but the methodology and results were very exciting. Again, published last week, in Nature Communications journal, which looked at bacteriophages against Klebsiella, showing beneficial outcomes in those animal models of PSC.
And what part of it were you not convinced by?
Well, I think the title was misleading in that it said that bacteriophages help PSC, but it's not a inhuman study. I mean, animals behave very differently. So it certainly helped an animal model of sclerosing cholangitis, but I think it's a bridge too far to say it reverses PSC in man without testing it in man yet.
And is Norurso available, as a treatment?
Still in trial. Well, the trials have closed recruitment in PSC now, and they're running in PBC still, but it is not available for commercial purchase in the United Kingdom, Republic of Ireland, and certainly not available in North America.
Well, thank you so much for your time.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.